Good afternoon. Can y'all hear me okay? Oh, there it is. Perfect. There's that echo. Good afternoon, everyone. My name is Zachary Cavins. I'm a local resident here of West Volusia and happy to be speaking with you. I've got Dr. Meeks in the back, my partner. We're both foot and ankle surgeons as well as podiatrists here serving West Volusia. And we're here to talk to you today about foot care and safety for the experienced adult. So without further ado, we'll get started. So, perfect. Work today. So real quick brief summary. We're going to talk about some foot deformities. We're going to talk about the skin and nail changes that happen as we get more experience in our life. Some bone strength issues that come on, as well as a quick topic on arthritis. Just to kind of give you a quick heads up, I will kind of breeze through some of this, and then we'll answer up the floor for a lot of just question and answer between Dr. Meeks and myself. So if anyone has any burning questions, we'll get them addressed for you today. So for deformities and aging, so everyone knows we got bunions and hammer toes. Everybody loves having those, right? We love seeing them, especially when you start getting pain. So shoe gear is going to be extremely important, but it's definitely more of a progressive issue. For those that have had any issues with bunions or hammer toes, you'll know that symptoms do get worse as time goes on. And then unfortunately with those big bumps and lumps, you'll get some calluses that will form. We all can definitely wake up in the morning and know that our foot gets stiffer. Things going to have to get broken in and moving as we start going throughout our day. However, it is sometimes easier to get some relief from cushions, but there are some other things that we can do as time goes on. So biggest issue really is shoe gear. Shoe gear. I've got some great pictures of shoes that people wear in their 20s, which we love seeing because you're going to become our patients one day, I promise. But modifications such as padding, we love our pads. We love pulling out our scissors and kind of making little arts and crafts there in the office to help kind of offload and cushion and protect. Dr. Meeks has quite a very large drawer, especially when he comes to DeLand to hang out with me. He goes through all of the different packages of padding that we have to take care of those hammer toes and those bunion issues and try to take away some of that pressure off of those bones and those bumps. Depending on how bad it is, if it's painful, we can't get you better with the shoes, we can't get you better with the injections, then there are some surgery options. Surgery now really isn't as bad as everyone first thought. Really, we have come a long way in terms of recovery. It used to be you would have a bunionectomy and you wouldn't walk for a month, and it was the world's most painful surgery. Now with Dr. Meeks and myself, we're doing surgery the same day. You're walking out the same day, minimal incisions, a lot smaller, and we can kind of provide relief a lot quicker, which is honestly a great relief for most people to kind of get you back doing those activities you love. This is one of my patients from this morning. As we know, as we get older, things definitely start to change, right? We can imagine like even our hands, right? So we imagine our hands when we were, say, in our mid-20s, that skin definitely becomes thinner, so we get those pressure points. So we're standing in the kitchen, we're doing things if we're outside, you're getting those pressure points that are there. And those pressure points, unfortunately, do lead to those corns and those calluses. So that's where that good shoe gear has a good space, where we're able to kind of take some of that pressure off. But if not, then you can come see us and we can kind of help there. Some sort to shave them down, give you some different treatment options. So what else can we do? We can look at your feet. You can look at your feet. You've got friends and family that love to look at your feet. If you have a hard time bending down there, then we got mirrors that can help as well. Big thing is just trying to prevent major issues. So we want to prevent those cracks because those cracks can then become deeper, they become infected, and those are really bad days for everybody. So we really want to make sure we protect them, moisturize them, look at them. If there's issues, please come see us. We're definitely here to help. We can kind of help give you some alternatives. Gold Bond, honestly, is great. Not to really pitch anything specifically, but it works pretty well for most people. I don't make money from them, but patients love it. It does a pretty good job. And we've got some things that are a little bit stronger, more compounded that we can prescribe as well. But honestly, just if it's more routine maintenance is going to get you pretty far. Oh yeah, toenail fungus. So toenail fungus, that's the bane of everybody's existence too. In Florida, we've got this wonderful moisture. Fungus kind of slips in under that nail It gets this great yellowy texture, brittle color. If it's bad enough, it'll start to smell bad. So there's different ways we can treat that. Sometimes we'll do some topical medication. If I've got any foot soakers in the room, like myself, I like to soak my feet. You're able to kind of put water in there. We got a host of compounding materials and powders that definitely help kind of treat some of that fungus. So if it's harder to get down there to do the topical applications every day, we have some really good topical powders that you can actually apply like in a foot bath, and that foot bath really does help penetrate, and we've seen a lot of good success in actually treating these fungal infections. Definitely a fight. So outside of the topicals that we talked about, you can come to us. We'll definitely trim the nails down. We'll remove that fungus, and this is one of my favorite guys. That's Jublia. He's out there definitely trying to fight the fungus. This is hopefully going to be me one day. So now we're going to talk about some bone changes. So definitely we all know as we get older, the bones definitely go through changes out throughout life, right? So the big thing is for everyone that's super active in this room, we know that the more active we are, we put more strain on those bones. We've talked about that loss of that cushioning. So now that cushioning's gone, the bones take on some more pressure. And as they take on more pressure, you can get these stress fractures that occur. So outside of the overall concern for osteoporosis, you can get some stress fractures. And so that's going to just lead to this persistent pain that's in the foot. Sometimes it can't be ignored. Everyone thinks that, oh, it's just old age. I love that line. People say, I'm just old. You're not old. Things can do and happen, so we have to make sure that we kind of protect it. And so having that good supportive shoe gear, whether that's a New Balance shoe, which I've been checking out the room, everyone's doing a pretty good job today. There's a few in there, but everyone's doing a pretty good job. But you want to make sure we kind of protect them. Oh, there we go. That's it. Those are the money makers. So what can we do to kind of protect our feet, right? So let's not overdo it. Let's be sensible. We want to walk on good surfaces. Make sure that ground beneath us is definitely going to be supportive. And then make sure we have a good supplement with our vitamins. Obviously, check with your primary care doctor. Make sure it's okay to take them. But, vitamin D and calcium are always going to be good. For supportive shoes, I love a good New Balance or a Rockport. They work really well. Skechers has also come a tremendously long way. Plus, they've got that slip-in, which is awesome for us because it's super easy for people to get on. So that's the big thing. It's like there are shoe companies out there now that have developed things for us that allow you to actually be safer as you ambulate throughout life. So the more you protect yourself up front leads to hopefully less problems in the future. And so while we love to see you in the office, I also would rather much see you guys at Publix. And arthritis, Uncle Arthur. So it can occur anywhere in the body, in any joint. We went backwards. I'm still new to computers. So it can happen anywhere in the body, in the joint. For the foot and the ankle, honestly, it's mostly post-traumatic. So compare that to, say, a knee or a hip that's more of that wear and tear arthritis. When it comes to the foot specifically, it's usually more post-traumatic in nature. Definitely can progress without age. The one area where I definitely see it more is kind of in the top of the foot, right where all of our shoes just cross right across the top. And so I call that area the wrist of the foot. There's a bunch of little bones there for some reason, just because it helps with motion. But as we age and get older and we go through all those life experiences, as we walk more, those joints take on more pressure and more of a strain. And so that makes walking kind of more difficult. Happens in the big toe tremendously, and therefore when you go to take and you go to get that push off, it can hurt. And then people will develop calluses secondary to those gait changes. So you'll sometimes get calluses on the side of the big toe, or you'll get calluses underneath the second toe, or you'll get this really big callus that we like to call a tyloma, which is all secondary to pressure. And so we try to offload that as much as we can with shoe gear. We try to protect it with those pads that Dr. Meeks and myself definitely love. However, not always successful, and then there are some things that we can do. So more advanced things, we get into, unfortunately, decreasing the activity. No one wants to do that. I want to see everyone be active. That's why we're going throughout life. Proper shoe gear, once again, what's the hallmark of this whole conversation is making sure you wear good protective shoes for your feet. The topicals, I've got a few that are pretty good that will help reduce some of these callus formations. And then, of course, you have different surgical options. That picture there is a total ankle replacement, which Dr. Meeks and myself also perform, because we're definitely still that foot and ankle surgeon, where those arthritic conditions were just too painful for patients, and we had to end up replacing their joint. And here's a bunch of questions. So I guess the first question everyone has is, is it normal to have pain? That goes back to that statement. It is not normal. It's not just old age. There are things such as arthritis. So pain is a big signal for us, right? It's our way of our body telling us, like, hey, there's an issue going on here. So please don't ignore that. For a foot and ankle surgeon like Dr. Meeks and myself, just because you come to us does not mean we're going to operate. There are some people in town that kind of get that confused. We are still podiatrists. We're still here to kind of manage you conservatively if we can, and surgery is our last resort. We want to see you get better on your own, and if you can't, then surgery is an option. But the real benefit to seeing, honestly, Dr. Meeks or myself as a foot and ankle surgeon is he and I have really dedicated our lives to the foot and to the ankle. Really, it's everything below the knee. So for ourselves, we studied 4 years of undergraduate, 4 years of medical school, solely focusing on foot and ankle, and then we did 3 years of residency where we only focused on foot and ankle surgery. Sure, we did some few general things and we worked with some other doctors, but really we were skipping out of those cases and we were covering the foot and ankle cases, right? Because at the end of the day, we are podiatrists. We want to have that foot and ankle experience. So, you know, a ton of bones, ton of joints, but that's really kind of why the foot and ankle specialist, especially as a surgeon, we have that space. And I appreciate your time. And that's a picture of my lovely family, as well as information for our office, which I'll be able to definitely pass out for you guys. You can scan that QR code that provides a link to the office for scheduling, and then we'll give some handouts as well. So thank you guys for your time. And I'll get Dr. Meeks up here on the stage, and we'll answer any questions you guys may have.
Hello, how's everyone doing? Like Dr. Cavins said, I'm Dr. Meeks, and now we're going to open up the floor and answer any questions that you guys have burning in the back. Anything at all, we're here to answer for you. What questions do you have? Anyone?
Neuropathy? Hold on, right behind you.
Yes, neuropathy.
What can be done? What can be done for it?
So there's a lot of different treatments for neuropathy. Neuropathy kind of expands a large category of problems, right? You can have back issues that can lead to neuropathy. Diabetes can lead to neuropathy, as well as a host of other vitamin and mineral deficiencies like vitamin B12 and folate. So oftentimes we'll do some testing to kind of evaluate where that neuropathy might be stemming from. That kind of helps us kind of focus in on how to treat that. Now, as far as neuropathy goes, it's very difficult to treat, okay? Oftentimes we'll start with either topical or oral medications to see if that kind of alleviates some of the symptoms, as well as controlling what caused that problem to begin with. After that, then there are other physical therapy modalities. There's other injections and pain management that we can go into, as well as offloading with shoe gear and different physical therapy modalities. There's a lot of different options out there, and we have to figure out what works best for you. Good question. Anybody else? Yes. We have a mic that we're going to pass around.
Thank you. I didn't pick up exactly what you were saying about shoes at the beginning. I'm looking at the two of you. You have rather thin-soled leather shoes. Are you opposed to these New Balance?
Absolutely not. So shoe gear plays a critical role in foot and ankle pain, right? So by myself, I don't know about Dr. Cavins, I don't typically recommend shoe brands for people. I tell you things to look at in shoe gear, okay? Because there's a lot of different shoes out there, and some people can't wear the same shoes that myself and Dr. Cavins can wear with comfort, okay? So really for me, there's 3 things to look for in a shoe, okay? When you go ahead and bend that shoe, really it should only bend at the toes. You shouldn't be able to fold that shoe in half. There's no support there, okay? When you don't want to be able to twist that shoe in half. I know some people out there see some of these thin running shoes. You can twist them and bend them. They offer no support, okay? And then the third thing is in the back of the heel. You want to have some support there where you don't want to pinch it together. Now, for myself, a lot of what goes into a shoe, you can actually build off of the insert itself that goes into the shoe. Sometimes that can be more important than the shoe itself, okay? Oftentimes, I'll start with over-the-counter inserts for shoes because they work fairly well and they're cost-effective, okay? Now, we do have options where we can do custom molded inserts for your specific foot. Sometimes they're a little bit more pricey, but they do work very well. How about you, Dr. Cavins?
No, I do actually recommend shoes.
I know you do.
But so I love New Balance. I'm a huge New Balance fan. I think New Balance has done a fantastic job with how they produce their walking shoe. There is a difference between walking shoes, running shoes, casual shoes. There are differences. And so in 2024, we've come a long way in terms of how we've developed the different polymers to support the shoe. So there are different types, and so we've come pretty far. So I like a New Balance in terms of a walking shoe. I think it gives you a lot of good structural support, kind of those same characteristics that Dr. Meeks talks about. It gives you good heel counter. It gives you good arch support with some limited motion in that toe box. And so for me, I'm a big New Balance fan. Rockport honestly makes a really nice dressier shoe that you can still have some level of support with. But that being said, I go back to Skechers have come a long way. You asked me this question 15 years ago, I would never recommend a Skechers shoe. But coming this far now, they've actually done really well. Their Go Walk series is actually really pretty decent. I see people every day. I get feedback from patients every day. Like, how do you like these? Like, how do they work for you? And I think the hard part for some patients is it's easier for them to get on. They want a lighter shoe sometimes because it's easier to walk around in. But truthfully, if you can't put the shoe on, it doesn't matter how good the shoe is, right? If you can't bend down to tie the laces, you're not going to wear them, right? So I got to find something that's out there that's going to make it actually work for you. And so I think the big thing, like he's talking about, is you want to find something that's going to give you some level of support that's not too flimsy, but still lets you have some level of comfort. So those are, I guess, my top three are going to be, it's the it's the Rockport, the New Balance, and probably a Skechers shoe.
So if you've got a good support shoe and you've got tingling under your foot, do you go for a pad that's softer?
Yes, ma'am. That's kind of where I would start. You can get some different forefoot cushioning, whether you do that through the insert itself. And that's where, truthfully, we talk about these arthritic conditions that exist. Over-the-counter orthotics do a pretty good job to start. They make them thick enough where it works. But the custom molded orthotic actually has a really good space. And Hanger Clinic is a provider that we have here in town that does custom molded orthotic devices. You got to get a prescription from Dr. Meeks or myself first. But we will prescribe them, but they work really well. So when most people think about orthotics, they think about this hard, really uncomfortable device, right? We think about that old plastic that we may have had when we were younger. Those still exist. We still write for those for certain types of patients. But for that more experienced patient that we're speaking to right now, the foot does not accommodate as well, right? We talked about early on, right? The foot gets stiffer as we get older. Arthritis kind of starts to set in, and the foot doesn't adapt the same way. So the nice thing about these accommodative orthotic devices is that they will let you hold the position of the foot. So the way I talk about it is it brings the ground to you. So your foot doesn't have to accommodate as much. We really just say, hi, my foot sits here, and we just bring the ground right up to it so your foot doesn't have to move as much. And so that takes away a lot of those abnormal pressure points and pain spots. So we try to go the over-the-counter first because it's cheaper, honestly. But if we're not getting there and you're going, I'm not getting my activity in, I'm not getting my walks in, I'm still getting pain here despite us using the cushions and the pads and the over-the-counter devices, well, then that's a time to maybe consider stepping up that cost. And not to scare anybody with what that means, but an over-the-counter device is going to run you probably $50, and it's going to last you between 3 and 6 months. An accommodated device, definitely much bigger in terms of amount, is around $400, which is a big number, right? But that's going to last you 10 years. So it's a big number up front, but long-term investment that's actually custom-made to you to offload your problem, that might be worth it in the end. So I tell patients we always start small if we can. If we make it work, it's easier to get that $50 every few months. But if we're not getting there and you're stuck inside and you can't do the activity you want, then it might be worth that investing in yourself. So that's my thought.
Absolutely.
Thank you.
Yeah.
Anyone else? Right up there in the front.
Oh, yeah. We got one in the front here. We got one in the back.
What type of treatments do you recommend? What type of treatments do you recommend for someone with gout?
So gout, there's a lot of things that also cause gout, right? So typically red hot, swollen, usually big toe. Occasionally does happen in the ankle, the middle of the foot, other places, but typically it's that big toe, right? So typically for myself, when we have an acute gout attack, you kind of know when you're getting those symptoms. You feel that achiness, you feel it getting hot, swollen. That's the time to come see me. So really, initially it's about calming down the inflammation, and typically I'll do that in one of two ways or both ways at the same time. Sometimes we do need a steroid injection to calm down that acute inflammatory response and help get rid of that pain. Oftentimes we'll also do some additional oral medication to kind of prolong that effect, whether that's steroids or the long-term, the colchicine that's been around forever. Now long-term, there's a bunch of different anti-gout medications. Typically for me, I don't know about you, Dr. Cavins, but I usually work with your primary care and kind of work with that to prescribe that long term to take care of it. Usually for me, it's more of an acute attack that I treat.
Yeah, I definitely second Dr. Meeks. For sure, for me, have you ever had gout before?
I have not.
Oh.
So
Well, I got stories. So once you forget that experience, it hurts, right? I'll never forget my first gout attack. I was in medical school in an anatomy lab, and if I could have broken my toe off, I think I'd have been better. It hurts so bad. So for me, we got to get those patients in. I definitely second those same thoughts. I will give, it's really an injection. It gives you that immediate relief. And then we kind of partner with our PCP docs to make sure that you're kind of getting that long term. If you're getting a gout attack every 3 months, every 2 months, every month, then we really need to consider some long-term medication. The way I kind of think about it is if you only get 2 attacks a year, 1 a year, then I don't need to place you probably on some sort of long-term pill that you need to take every day. If you can just come and see one of us for a quick injection, then you're feeling better usually within the next 2 days. So a lot of that has to do with your personal preference. Like some people are like, I never want that pain ever again, so they'll take the medication with the help of their primary care docs. But for most of our patients that get them, I will say if it's less than really 2 attacks a year, they're coming in to kind of see us for that acute flare-up, get their shot, and feel better usually the next couple of days. And a last question, if none of that works, there is surgery we can do too.
That's the last.
And then there was a question in the back by the column, and then the nice lady in the green top.
I've had several friends who've had to have hammer toe surgery several times on the same toes.
Yikes.
What do you do to prevent or fix it so it doesn't come back?
Yikes, toes.
Yeah.
That's all you
So
for me.
recurrent hammer toes, difficult to treat. So, hammer toes are a difficult thing to treat because you have to work on the balance of the rest of the foot. A lot of those tendons that actually go to the toes start in the back of the leg. That's a long way to travel, and they're great big muscles and tendons that pull a lot. So we have to actually balance those, usually at the same time that we fix those toes. Now, there's been a lot of different implants and different fixation types that have happened over the years. Historically, we used K-wires that got pulled out in the office afterwards. I really try to avoid those at all costs because I don't know about you, but I don't like a wire sticking out the end of my toe that I get caught on the bed sheets all the time. So now we went to implants. Some of these implants, they don't hold quite as well. So I know about myself and Dr. Cavins, we've actually went to a screw. They're relatively inexpensive. They work really well and they're really strong. Gets that toe nice and straight and holds it straight where it can't bend again. After that, it's about balancing the tendons so that that toe remains straight with the rest of the foot, okay? So I've had pretty good results with my hammer toes since going to this way, where they don't typically come back. That's not to say that they never come back, because there's nothing 100% guaranteed, unfortunately. I wish there was. Anything you'd like to add to that, Dr. Cavins?
No, I mean, definitely the soft tissue balancing is the most important thing. I would say that when we talk about hammer toe surgery, the biggest complication we get is called a float toe, and that's where that toe wants to deviate up into the air. The body is an amazing machine. It likes to scar, it wants to heal, it wants to get better. And so unfortunately that contracture or pull will let that toe kind of raise back up. So I think the one thing that I've definitely has educated the patients that we have are, we need to try to stretch those tendons out. I have a few devices that we have you pick up from Amazon that are like $9 that allow that toe to kind of be worked in a different position that kind of keeps that tendon out to length, because that's the last thing that really any of us want to see is when you have a patient with cosmetically looks so much better, they go to stand and that toe just wants to sit up in the air. And so then they start talking about pain underneath the metatarsal, and now, what we thought was actually correcting now is causing more of a problem. So I would definitely be lying to say I've never had a float toe. I definitely have had float toes, but the big thing in how we kind of both manage patients is we like to see you guys pretty frequently. So throughout your post-operative course, I'm checking on you, and initially every week you're in my office. After that, you're there for every couple weeks, and then you're there up until 1 year. So I had this happen actually the other day. I had a lady, I fixed her bunion, 5 hammer toes, a Taylor's bunion, lengthened a tendon in the back, scoped her ankle, and she came to me at 3 months out and her toe started to lift. I had her back in the OR within 3 days, and we would actually put her tendon back down because I didn't want to see that toe come back up. minimal, she still was able to walk on it, but we're able to address the tendon issue quickly. So that was the one thing that I think I've always kind of harped on my patients is please come back and see us in this throughout your post-operative course, because if there's an issue, we want to address it. The last thing you want is to have something, you miss it, you go out 3, 6, 9 months later, and something that could have been addressed much quickly now is more of a problem and more of an issue. So I would say it's definitely a problem. The soft tissue balances are tough. Toes are really hard to navigate. There's, 28 bones of the foot, ton of joints, ton of ligaments, all kind of working, and it's the only structure that we have in our body that has surgery that you walk on, right? No one has their appendix removed and walks on their stomach the next day. No one has arm surgery and walks out. If people walked on their hands, I guarantee foot surgery would be so much easier, but we're not there, right? So if anybody wants to try, I've offered it. No one's done it for me yet. No one's walking on their hands after surgery, but that's kind of what we're up against. So definitely a problem. There are some other tendon techniques that Dr. Meeks, I know, is definitely trained on, as well as myself, where we'll transfer tendons to help those toes, where it's not just all osseous or bony work. We will be able to address some of those ligament issues or tendon issues, where we can actually transfer some tendons to help hold that toe down. And once again, if all that fails, we try to leave the pin out if we can. I think we had a question in the far back next to the pillar.
Yeah, we talk about acute conditions and circumstances, and we all know that Medicare and those of us that have supplemental can help with that. But when you get into a certain age and your toes are deforming and your toenails themselves are deforming and your other joints aren't doing so hot, it gets difficult to do the trimming of your nails. I hate doing it. So at what point does Medicare help us when it comes to chronic care of the feet, when it comes to this difficulty of even just clipping toenails? Does Medicare and supplemental help with those needs?
So there are qualifiers to essentially meet what's called medically necessary foot care, okay? So these are a set of guidelines that Medicare has established that allow Dr. Cavins and myself to do the routine foot care. Okay. Now, there's a lot of different things that can qualify for this, but historically it's been neuropathy. Diabetes with neuropathy is one. Peripheral arterial disease or bad blood flow that's been documented is another. Okay, as well as anticoagulation. Those are really the 3 big ones that would qualify for somebody to come in and do the medically necessary foot care. Through that, what we do is we trim up the nails, right? We make sure that you don't get any cuts, scrapes, scratches, things like that can lead to, number 1, bleeding, number 2, infection. That's what we're trying to prevent, right? Because if you can't reach the toe to trim the nail, and I've seen it before, you end up clipping it into the toenail, into the toe, you get a little cut, it gets a little infected, and those turn into big, big problems. I know Dr. Cavins has seen it more times than we can count, and we want to prevent that from happening, because historically when I see patients, most of them have 10 toes, and I tell them, there's 10 great toes, and I'm pretty sure you don't want them going anywhere, right? So that's what we're trying to prevent, okay? And then number 2 is being on the anticoagulation. If you've ever, bumped a coffee table or got a little cut or scrape or scratch and it takes 3 days to stop bleeding, well, that's not good either, right? So what we're trying to do is prevent that from happening. Anything else you'd like to add?
So that's a Q7 modifier for those playing billing coding at home. Yeah. So if you've ever lost a toe or what they consider an integral skeletal portion of the foot, then that does qualify you. But those are unfortunately really the guidelines that, in order to have insurance cover it, it's, non-traumatic amputation, PAD that's been documented typically by a vascular specialist or neuropathy. And then it has to also come with a couple other, digital deformities as well. But it does make it kind of difficult for us because we are here to kind of help take care of patients. I know that we work for Advent, but from a billing standpoint, if it's not qualified, we do offer like non-covered care, like basically amounts that you can talk about still coming in to get medically necessary foot care, just non-covered. And so there are pathways where you can basically pay a self-pay fee for that non-covered care. With Medicare, you do have to sign a waiver, which we're kind of getting into the weeds a little bit about billing practices, but there is a pathway basically at the end of the day for you. So if you're like, hey, I don't want to do this, I can't do this, I don't feel safe doing this, I've got patients that definitely come and see us. I call it the 5 and 5 plan. They kind of come see me every 5 weeks, they sign their form, we do their nails, and they go about their business. So there is a pathway for you if you don't kind of meet that standard set of criteria.
Right there in the middle.
Hi,
Hi.
thank you for coming today.
Thank you.
Is there any connection or treatment plan that involves like physical therapy that might be working with the shin muscles, the calf, the whole leg actually?
Oh, absolutely. I mean, if you think of the body, really everything's connected, right? So, like the song goes, the knee bone's connected to the hip bone and all that. So from a gait and walking perspective, essentially from the lower back all the way down to the foot. Really, there's muscles that go down the whole way as well as nerves. So yes, Dr. Cavins and I work closely with our physical therapists. I know your physical therapy office is right next door. Mine is right across the street. So we talk with them and refer back and forth all the time. They send us updates on how our patients are doing, the progress they're making, and any kind of changes or suggestions that they have for therapy. So a lot of times what we'll do is actually work on muscle balancing, okay, where you can actually increase some strength or even stretch out a lot of the muscles. What we see a lot is the Achilles tendon gets very tight. It's called equinus. We see it, 75% of people, in all honesty, have this. What that leads to is you can put too much weight on the front of your foot. That can lead to those stress fractures. That can lead to arthritis. That can lead to a bunch of different problems, including flat feet and other ankle pathologies. So stretching out the Achilles tendon is one of what I call my Achilles heel, right? I always work on stretching out the Achilles tendon. It's a very big muscle in the foot and ankle. It's the only muscle really that crosses 3 joints, okay? It goes above the knee, crosses the ankle, as well as the joint under the ankle. So it really affects the foot. So we work very closely with physical therapy, even at-home physical therapy. And coming to you, there's all kinds of options that we have.
Perfect. And you guys have physical therapy here too, don't you, through
Correct.
Oak Park? So that's definitely something that if you need it, we can always prescribe it, and we work closely with those physical therapists as well. But definitely, working on balance, and it's the other who are PT too. Balance is a huge issue, which we all can probably relate to. I was actually talking to my wife the other day. I was walking through the room, and all of a sudden I got a little dizzy, and I said, "Oh, that didn't happen when I was 18." So definitely balance is a big issue for us, and that's one thing I know. Like even when we see patients in the office, they'll say, "Doc, my balance is getting pretty tight, pretty rough," and so we'll just do a referral over to them. They'll work on some balance and equilibrium things to kind of work on that balance to make sure we don't fall, because that's the last thing anybody wants. No one wants to break a hip. No one wants to break a leg, unless you're doing a great dance show. But no one really wants to see you break anything. So that balance is incredibly important. So definitely partnering with PT is a big deal for us.
One right up front.
What part of the foot affects balance and how to fix that?
It can really be any part of the foot. It can even be the knees and the hips. So I've seen multiple people come in with imbalance. And when we do an exam, I watch them walk. I'll measure them in the office. And I've seen a lot of times they have actually a limb length discrepancy, where sometimes the femur or the tibia, which is the bone under the knee, or even in the hips are uneven. And what we can do from that standpoint is, again, work with physical therapy to help with the balance. And sometimes we'll need some heel lifts or even custom orthotic to go into the shoe to help even all that out. And I've seen people even just purchasing over-the-counter heel lifts have tremendous increase in balance after years of instability just because they didn't know, right?
In the back.
I've had real bad high arches that have fallen, sort of, and I have a huge high instep. Wearing shoes hurt.
Mm-hmm.
The solution to that has been the New Balance with arch supports, but you guys are going to be horrified. The thing that freed me the most is arch support orthotic flip-flops.
Mm-hmm.
What is your opinion of that?
Flip-flops, that's a touchy issue. I'm a realist. It's Florida. It's hot. Everybody wears flip-flops and sandals. So I never tell you not to wear them. I tell you, again, things to look for. So there are a bunch of different brands of sandals and things like that that do have even a little bit of heel lift, a little bit of an arch support that are better than others, right? So again, for me, comfort, okay? And I'm a big fan of if it's not broken, don't fix it, right? So if what you're wearing is working and you're not having pain, you're not having decrease in function, you're able to do the things you want to do without having to take a pill, perfect. That's a win. Keep doing it. Okay?
Yeah, I couldn't say anything. That's perfect. I completely agree. I think that's where I think he and I both agree on the mentality of, if being home, stuck inside your house, if that's really what does it for you, then go for it. But no one really wakes up in the morning and goes, I never want to leave my house. So if you wearing that sandal gets you out, gets you going, it may not be the best thing, quote unquote, for your foot, but it's the best thing for you. So it's more about, right, it's the life in years, not the number of years in your life. So that rings true for, for me and how you manage patients, right? So we're here to kind of give you a overall guide, but at the end of the day, treatment really is patient specific.
What about the, I don't know how to say it, OOFAH?
Yeah, beautiful.
Yeah. I've had a number of patients that actually wear them with good relief. So, I have recommended those in the past. Again, it's that comfort and you doing the things you want to do that gets you out of the house, doing the activities you want to do. Okay, so, again, UFOs, have no problem with them in all honesty.
Yeah. I'm a big believer in the O-foam. I'm a big believer in the O-foam myself. I have my own set of UFOs, my wife, and as well as my brother-in-law, sister-in-law. We all believe in them. I think they feel great. The one thing I will tell you, though, about an UFO is that don't walk for long periods of time in them. So it's not like an exercise sandal. It's a recovery sandal. So if you've gone all day, you're coming home, you're going to be in for the evening, and you want to slip into those, they definitely will give you that cushion, that little level of support, but it's definitely designed to take some of that pressure and cushion off. So after I finish out, 14, 16 hours in the hospital, I'll go home, I'll slip into those, and that's what I'll wear around the house in the evening time. I wouldn't tell you to go for a walk around like the lake in them. I would even be hesitant to tell you to go for like a day of shopping with them, because the more active you are, they can give a little bit, and that can cause some ankle issues. So that happened to my sister-in-law. She was trying to walk in her UFOs for some reason, and she ended up coming to me. She was telling me, I've got pain on my ankle now. It's because the way that UFOs was kind of taking that support off of her foot was pushing more pressure on her ankle. But in terms of everyday wear, that's definitely my go-to, personally, my go-to sandal when I go home.
I have, over the last 6 months, found that I've begun to, toe drag is starting to become part of my walking pattern. I use a cart now instead of the cane. The toe drag is not on the same foot. It is, and I know part of it is when my legs get tired from the walking pattern I have, but just where am I headed?
So again, we'd have to evaluate that and kind of see where that is coming from. Is it neurological? Is it muscle? Is it bone? What's causing that exact problem? From that standpoint, then we address that problem. So if it's neurological or musculoskeletal, sometimes we can get you into some physical therapy and again, work on that balance and that strengthening. Sometimes if it's neurological, where the nerves aren't quite firing as well, sometimes we do need some extra bracing, okay? There are a number of bracing that we can do that actually will help pick that foot up. And again, the risk we run into is if you're walking and catch that toe, you tumble over the front and we have bad issues, right? Again, like we said, nobody wants to break a hip, nobody wants to break an arm, nobody wants to have those issues that keep us down for a long time. So sometimes just a little bit of a brace to help lift that foot up, take the pressure off and allow you to walk normally is what's needed. And again, that would be a prescription from either Dr. Cavins or myself. Right?
Question in the front?
Right there in
She's
front.
coming around.
Okay, I had a joint fused in my foot a couple years ago, so I can't move it either way, up or up and down. The first thing about the shoes, the New Balance is what I was recommended to wear, and that's what I wear all the time. But if I want to wear sandals or if I want to wear dress shoes, I can't walk. I mean, I can walk, but it hurts. So is there any other recommendation as far as, other than tennis shoes, for people with this issue?
Subtalar. Did you have a subtalar joint fusion?
That's kind of what I was wondering.
Was it
I-
a subtalar fusion? You know what you had fused?
Sounds like it, yeah.
Yeah.
It was the
I'd have
it was
to
the
In the
joint
back.
below the ankle in the back of the
Yes.
foot.
Yes.
Yeah.
I had 8 incisions, so, to get there.
Eight incisions.
8 incisions. They also did the Achilles tendon,
Achilles
they had to
tendon,
pull
that
it
makes
up.
sense.
Gotcha. Yeah, so, fusing that joint doesn't allow for what's called inversion and eversion, right? That's when we move the foot like this, right? You can still go up and down, but side to side.
Very little.
Yeah, so that causes a lot of difficulty, especially on uneven ground. Okay, that's why we always recommend some supportive shoe gear like a New Balance, right? As far as dress shoes, they can be a little bit, they're flat, they don't have much of an arch support. So from that standpoint, sometimes we will need that custom insert to go into that shoe. As far as the sandals go, there's a lot of different brands like Bionic and things like that that give you that arch support where we don't have that collapse because you don't have that motion,
So
right?
bionics.
Yeah.
Okay, the second thing was, from the surgery, I have my big toe.
Mhm.
When I walk barefoot, it sometimes just goes under because it doesn't lift. I think it was because of the surgery, or could it be something else?
That's very difficult to evaluate. Obviously I wasn't there in the surgery, so I don't know what happened. But a lot of different things can cause that toe to become unstable as far as alignment of bones, tendons, nerve issues, things like that, as well as sometimes when you're walking, if you're just catching that toe on the ground again. Sometimes we just need to work on strengthening everything up with some physical therapy. It can very much help with gait and stability. Sometimes, unfortunately, surgery is needed, right? It depends on what the issue is. So that would be a time that Dr. Cavins or myself would evaluate, take some x-rays, and make sure that, nothing's broken, nothing's out of place, nothing's dislocated,
Yeah.
and then go from there, right?
Okay, yeah, because I've tripped over it many times.
Yeah.
Thought I broke it a couple of times because it turned black and blue, but I've gone into walls because of it.
Oh, man.
Yeah, so maybe
How
I'll
far
come.
out are you from surgery?
Yeah, that was my...
How far out are you?
2017.
So, yeah. Did this happen directly after, or I guess to kind of not to flush it out too much and share your business, but when did you notice that contracture occurring?
Probably about a year after. I lived in Kansas City at the time. I didn't go barefoot as much, but here I go barefoot a lot, and so I can be walking and all of a sudden, without even knowing it, and I go forward.
Yeah, we'll get you in for an appointment, take a look at
Yeah.
you.
Yeah, the tendon that actually flexes the big toe sits right behind that subtalar joint. So sometimes it could just get trapped in some scar tissue. Sometimes it could be anything like that. So we'd have to evaluate that and see how the motion is.
Okay, thanks.
Mhm.
Anyone else? No more burning questions. Well, good.
Thank
That's
you.
what we were here to do.
Happy to hear that.
Okay.
Well, thank you guys for your time, and thanks for having Dr. Meeks and myself. And
Absolutely. If you have any other questions, feel free to contact the office, reach out. That's what we're here for. We're here in the community to help you do the things you want to do. Okay? Well, thank you for allowing us to come up here and speak with you.